Fitness for the deaf and hard of hearing. Hearing impairments. Deaf is one of the main forms of hearing impairments. It's very little to no functional hearing at all, even with the assistance of hearing devices. The experience varies greatly on when the onset of the hearing loss occurred. There's prelingual and postlingual. This is being based upon when language developed. Then there's congenital, which is present from birth. And there's adventitious, which occurs throughout the lifetime, and it can occur randomly or it can occur gradually. Hard of hearing is mild to moderate hearing loss. The severity levels are mild, moderate, severe, and profound. They get worse as the decibel levels get higher. So, how does the ear work? The ear is divided into three main areas. The outer ear, which is the visible area, this captures sound. The middle ear, which is the eardrum and tympanic cavity, this passes along and amplifies the sound via the ossicle bones. Then there's the internal ear, where the waves get transformed into nerve signals via the hair cells. These hair cells, when they're damaged, never grow back, leading to permanent hearing loss. And the internal ear is also the area that affects balance. Types of hearing loss. Conductive hearing loss is physical impairment that stops sound from traveling. A common form of this is earwax buildup, and a more uncommon form is oscillosclerosis, which is excessive bone growth in the middle ear. Central neural hearing loss is an inner ear dysfunction. An example of this is Meniere's disease, which is an inner ear fluid disorder. This can actually affect balance because it affects the inner ear. There's mixed hearing loss, which is conductive and sensorineural hearing loss. And finally, there's auditory neuropathy spectrum disorder, which is damaged nerves resulting in scrambling of the sound. Adventitious hearing loss. Some forms of this is diabetes, which is due to nerve damage as well as capillary damage, leading to issues with signal transmission. Those with diabetes have 2 times the chance of having hearing loss. Hypertension causes inner ear hemorrhages. Age-related hearing loss is just a natural progression. 1/3 of people ages 65 to 75 years old have hearing loss, and half of people 75 and up experience hearing loss. Different medications also cause hearing loss, such as chemotherapy. This treatment is toxic to sensory cells, and this leads to clinically significant hearing loss. More than half of cancer survivors experience hearing loss. Acoustic neuroma is a tumor that grows on or around the auditory nerves. Physical head injury, oxyticity, and sound exposure, as well as a ruptured eardrum, also can all cause hearing loss. There are 2 main kinds of congenital hearing loss. There's prenatal, which can be either caused by an infection during pregnancy, a low birth weight, maternal diabetes, alcohol or drug use, high blood pressure during pregnancy, or low oxygen levels. There are also genetic causes which can be developed later in life but are typically present at birth. Some of these are Down syndrome or Waardenburg syndrome. There's a correlation between physical head injuries and hearing loss. There's 2 main types. Inner and middle ear injury, which typically results in conductive hearing loss. As long as the cochlea is not damaged, there is a full regain of hearing. The brain will heal, and typically surgery is not needed. There's mechanical damage, which is damage to the auditory cortex, which is the temporal lobe, causing central hearing loss. This is neurological damage, causing a signal transmission issue. Signs can also go missed very commonly, as they are typically associated with cognitive deficits associated with physical head injuries. Weightlifting and hearing damage. Heavy lifting can cause straining, increasing internal pressure, which eventually relates to the ear. This is similar to what you would experience on a plane takeoff. Ways to avoid this straining on the ears would be avoiding the Valsalva maneuver, activating the jaw by either yawning or chewing gum, and not lifting outside the capability. Prolonged sound exposure can lead to hearing loss. Typically, sound over 70 decibels, depending on how long you're exposed to that sound, can cause hearing loss. Typically, sounds over 120 decibels could cause immediate hearing damage. So there is a correlation between weight slamming as well as exercise class music with sound exposure and the eventual hearing loss. There are actually statistics that say 30 out of 100 aerobics instructors say they experience tinnitus, which is ringing in the ear, about 50% of the time. Some treatments or solutions are early education intervention. So this is for students that experience prelingual hearing loss. This could either be teaching sign language or finding ways to adapt the student into the classroom. There are hearing aids. There are assisted listening devices. An example of this is when a teacher will wear a device that connects to the student's hearing aid and the sound is directly transmitted to the student. There are corrective surgeries. There's bone-anchored hearing aids. A typical one of this is the cochlear implant. Additionally, sign language is used as a form of communication. Balance and hearing loss can be connected. When there's damage to the vestibular system, the area that provides the brain with information about balance, motion, and head movements and position, this issue, which is affecting the cochlea or the semicircular canals, will affect balance. While the issue of balance and hearing is not mutually exclusive, one does not strictly entail the other. So, if the system is damaged, balance or control of eye movements or head, neck mobility, or even a sense of orientation are all adversely affected. Some of the causes that affect balance as far as hearing loss goes are inner ear infections, trauma to the inner ear, such as a head injury, or infection. And this can directly damage the inner ear, or it could be due to an inflammatory response. So, how does hearing loss affect exercise and physical activity? Well, there's really no correlation between hearing loss and lower athletic capacity. There's really no difference between any hearing counterpart. Although there are some early studies showing research that says there's a correlation between full hearing loss and certain areas of lower muscle strength. These areas were low core strength and low grip strength. Additionally, there are early studies on age-related hearing loss and physical activity. These studies look at higher physical activity throughout the life, resulting in a higher retention in hearing capacity. Another thought on this is that physical activity is known to improve cognitive function, so it could make sense that hearing capacity could also be improved. Some training considerations. Generally, the original cause for adventitious hearing loss is the issue that needs to be considered when training. Additionally, hearing loss that affects the vestibular system needs further consideration for both training balance and implementing safety precautions and exercise modifications. Additionally, communication is extremely important. So either having an interpreter or using key signals, learning basic sign language, or even having certain signals or cards that you can use between that just work best for your client. Eye contact and facial expressions are really important, as well as implementing repetition. Additionally, assisted listening devices can be used, as well as the client can keep the hearing aid on most of the time, although with certain hearing aids, they do need to be removed for certain exercises. Visibility is also extremely important. So demonstrating over and over again is extremely important. Using very visual cues, as well as the most important, I think, is making sure you're in a spacious, calm environment. So reduce any unnecessary visual stimulation. Overall, take extra care to reassure your client understands and feels fully confident in whatever exercise they're executing. For testing, for my aerobic test, I would use an inch strength rhythmic cycle ergometer test, which is a 6-minute endurance test. For muscle strength testing, I would use a hand grip dynamometer. This is because of some of those studies I talked about prior about the correlation between lower grip strength and hearing loss. Additionally, there's a correlation between such fine motor movements of like sign language. Another correlation would be like people that knit a lot experience a lot of carpal tunnel. So it could make sense that people that use sign language could be experiencing more syndromes that affect this area of the body. Additionally, I would do a 3-rep max test. This is because I wouldn't want to cause too much internal pressure in the ears. This wouldn't apply to every form of hearing loss, but generally to be safe, a 3-rep max would be best. For flexibility, I would do a sit and reach. And for balance, if I were to use it, I would use a Y balance test. For those who experience balance issues due to inner ear dysfunction, I would only do the test if there's the necessary safety measures, such as a harness or a lot of padding to make sure the client wouldn't experience any injuries. For those who don't have any balance issues, I think it wouldn't be completely necessary, but it could be good to get a good baseline. For my case study is Stephanie. She is a 29-year-old female who has congenital hearing loss, meaning she's been deaf since birth. She has used sign language as her primary form of communication since birth. She has high blood pressure. It's 145/90, meaning she has hypertension. She takes a beta blocker, and her goal is to run a marathon in 1 year. For the FIT recommendation, those who are deaf or hard of hearing generally don't require a specialized FIT recommendation. Thus, the client is more fitted to follow the FIT principle for hypertension. For flexibility, I would have her doing 2 days a week of yoga and stretching after each bout of exercise. For resistance, the program should start at 2 days a week and progress to 3 days with 3 sets of 8 to 12 exercises each. This should be at a moderate intensity. For aerobic, the program should start with 5 days a week, with each bout of exercise being at least 30 minutes. Eventually, this should progress to about 7 days a week, with most of the days being prolonged aerobic activities. It would be best to avoid treadmill activities as a precaution, and this should be performed at a moderate intensity. And these are the references.